Hello, and welcome to today's AppMan TechTalks webinar, hosted by the AppMan Surveillance Response Working Group. I'm Professor Richard Maud from Morrow in Bangkok, and I'm the co-chair of the SRWG, Surveillance and Response Working Group. So today's webinar is on enhancing community-level surveillance to ensure quality services and sustainable malaria elimination. So as background, as malaria programs across the Asia-Pacific near elimination, effective surveillance at the community level becomes increasingly crucial to sustain gains and prevent resurgence. So community-level surveillance captures critical data on disease trends, intervention impacts, and at-risk populations, guiding timely response.
Hello, good afternoon. Sorry I'm late, but now is fine.
Welcome, Professor Stewart. So we're just going through some opening.
Professor Richard,
Hello.
Is work for me now?
Great. Maybe would you like to take over the opening remarks?
Okay.
Thank you.
Good afternoon, good morning, good evening, and my old friend and new friend. Thank you for your participation in this very important event today. And I really sorry a little bit later, and welcome to the today's AppMan SRWG Tech Talk webinar with the title of Enhancing Community-Level Surveillance to Ensure Quality Services and Sustainable Malaria Elimination. First of all, I would like to extend a warm welcome to our esteemed panelists, moderators, and all the participants joining from across the region. I'm grateful for your time and participation in this important conversation on understanding surveillance gaps and needs at the community level. Second, I would like to express my sincere thanks to all the friends in the malaria field to support my working as a co-chair of the AppMan SRWG during the last 2 years. As my time as the co-chair of the AppMan SRWG is coming to the end after 2 years of the leadership, I reflect on the significant progress we've made together during the last 2 years. It's been an honor to lead this group and work alongside so many dedicated experts across the region. Particularly, I love the term of the surveillance and response, because actually I did using this name for the arrange the meeting since 2012 in China. This is a biannual meeting, and we attract a lot of people to working on the surveillance and response system, leading for the tropical disease elimination. So from Chinese perspective, as a malaria-free country since 2010, so we have witnessed the firsthand the critical importance of a strong surveillance system even after the malaria elimination is attached. So the malaria-free was actually in China 2021. And over the past 2 years, I have had the privilege of the leading of SRWG alongside Professor Richard Mulder as we explore the innovative solution to strengthening the malaria surveillance and response. China has been at the front of these efforts, sharing our experiences and lessons learned as a country that has achieved malaria elimination through the various AppMan engagement channels. Our leadership has been focused on ensuring that even in the absence of routine malaria cases, effective surveillance can remain in place. From Southeast Asian region's perspective, as we approach malaria elimination in many countries across the region, the role of the community-level surveillance is more critical than ever, even as the malaria case decline. We must ensure that our surveillance system remains strong enough to detect the cases and respond in a timely. This is a key to sustain zero prevalence and preventing the reestablishment of malaria in our communities, supported by One Health agenda. Of course, one of the issue I would like to say that I missed several meetings. I really apologize. But although I was unable to attend the joint RWG and VIVAX WG annual meeting in Kuching, Malaysia, I would like to commend this astonishing level of the engagement from 19 partner countries. This is a true testament to the region's dedication to eliminating malaria and coming together to share best practice and lessons learned. The outputs from this meeting will be vital to shaping the future direction of the SRWG and the VIVAX WG, ensuring that we continue to address the challenges and the needs of countries working toward malaria elimination. I found one of today's presentation is focusing on the findings from one of the group working activities from the meeting, which will help us understanding the gap in our routine community level surveillance and explore how to bridge these gaps with both new and existing tools in our portfolio. Third, today's webinar will focus on the maintaining and improving community level surveillance to support malaria elimination efforts. Our panelists will share valuable insights from their respective countries, including the Bangladesh, Bhutan, and Laos PDR, on the challenges they face and innovative solutions they are implementing. We look forward to an engaging discussion, and I encourage everyone to actively participate, ask questions, and share the ideas on how we can strengthen surveillance system and ensure they continue to meet the needs of our communities. Last but not least, I expect today's agenda will give us more hints to promote our surveillance response system leading for malaria elimination in the region. And once again, I would like to sincerely thank our panelists for their time and contribution, and to all the attendees for their participation. Now, I will hand over to my co-chair, Professor Richard Maud, who will take us through some housekeeping and introduce today's moderator. Thanks.
Thank you very much, Professor Zhou, and it's been a pleasure sharing with you over the last 2 years. It's been a wonderful experience. So I'll quickly move on to the mechanics of this webinar, just for participants to be aware that you will be muted and your videos are off, but you can comment in the chat. So introduce yourself, make comments. And you can also put questions in the Q&A, which is a separate button at the bottom of the screen. And then you can also vote on the questions that people enter, and we'll try and get to as many as we can, providing that we have time at the end. So we also do a couple of polls during this webinar, including a feedback poll right at the end. So we're very lucky today to have Professor Maxine Whitaker to moderate. So she's the CSO representative to the RAI Regional Steering Committee. In the interest of time, I will hand over to Maxine now. Thank you.
Thank you very much, Richard, and thank you for this opportunity. So if I could have my slides, what I'll do is just set the scene with just a couple of slides, and then I'll introduce the panel, and then they will all each have 10 minutes to talk. So if I can have my slides, thank you. So thank you, next slide. So basically, as people talked, we're looking at malaria elimination in this region. And one of the things we need to do is monitor, evaluate, and learn as we try to reach malaria elimination. And I see this as a bit of a box. Sometimes people see it as a black box. But what we need to do is take a range of views around this. We need to have the community views, the client views, managers' views, funders' views, providers' views, and various groups within the community's views about how well we're achieving that goal of malaria elimination and prevention of re-establishment, and are we doing this inclusively and equitably. All of that needs to be part of a monitoring, evaluation and learning system of all of the partners providing malaria services in the region. It needs to be action and response orientated. Everyone shares that same aim of elimination and prevention of re-establishment. And to do that, you need to actually enhance services, performance, have continual quality improvement, and have that universal inclusive coverage, not blaming or criticizing people, but getting facts to help improve services to reach that joint aim. This data can be qualitative, quantitative, or mixed. So on the next slide, I just introduce 4 terms that are often used when we talk about community data. First, there's community data. That's data that is relevant to the communities that services are being provided. Often it's achieved through routine health information systems or other formal systems, may also come from special studies and surveys, and could also be patient feedback through patient feedback boxes, or even the use of apps to collect data from people who are using services. Second is the term community-based surveillance. The community may collect qualitative or quantitative data on various aspects of health programs and of the services provided to them. What is measured is requested by the government or the donors, the funders, and is usually made available to external people, not always necessarily going back to the community. Community-based surveillance is particularly around surveillance of public health events, and it's using the community, often through a syndromic approach, to collect data for early detection and reporting of public health events, in this case maybe malaria, and it can help prevent, detect and respond to disease outbreaks quicker by the government services, but with the community. Community-led monitoring, the community decide what data they want to collect, again, maybe qualitative or quantitative, around the programs, the malaria programs and services being provided to them. They decide, and then based on the results, which they analyse, they then work with their partners, service providers, maybe government managers, to identify actions to address these findings and then follow up to see if those actions to make change, improve services really have taken place. Next slide, please. And so when we're talking about malaria elimination and prevention of re-establishment, there are a range of questions we may ask. We might ask a monitoring question. Are we actually doing things right? What we'd planned, are we doing it right? We may want to know, are all the people who we expect to use the services using them? Why or why not? And that may also have a gender equality, disability, and social inclusiveness lens to it. We might want to evaluate, are we doing the right things? We might want to understand about coverage levels. Are we reaching the coverage levels we need to reach? We might want to understand, are we actually finding, diagnosing and treating effectively all people with malaria? And we may want to ensure that we've got a surveillance system that is sensitive and specific. And different tools can help answer these questions. No one tool can answer them all. And that's really what we're going to now hear from our panelists. So hopefully with that introduction, I can now hand over to our various panelists. The first panelist is Dr. Mohammed Islam, who's the Senior Director of BRAC in Bangladesh, used to be the Bangladesh Rural Advancement Committee, but so famous we now just know it as BRAC. So he's the Director of the BRAC Health Program and Humanitarian Crisis Management Program. Our second speaker will be Mr. Tenzin Wangdi, who is the Chief Entomologist of the National Malaria Program from Bhutan. And then we'll hear from Mr. Vienkorn Surya, who's the Program Manager of the Community Health and Inclusion Association, or CHEERS, in Lao PDR. So Dr. Islam, over to you for your 10-minute presentation. Thank you.
Thank you, Maxine. Yeah. Good morning, afternoon, good evening. Yeah. So may I now request to show my slide?
It's up. Think we've lost Dr. Islam. So maybe for the sake of time, Mr. Tenzin, do you mind starting? And we'll just go to your slides first.
I came in.
Oh, you're back. Okay, good.
I came in. Yeah, I'm back. I'm back. I'm back. Sorry. So so maybe I will go. Yeah. Request for the next slide. Start presentation. Next slide. Can you hear me?
Yes, Dr. Islam, I'm on the malaria
Hello?
Bangladesh scenario slide, your second slide.
Or I'm lost. I don't know. Yeah, thank
Maxine, I
yep.
think maybe we let Dr.
Go on
Islam.
to
Yeah.
Yep. Go on to Tenzin, and then we can let Dr. Islam reboot. Thank you, Tenzin.
Hi, good morning. I hope like I'm audible.
Yes, we can hear you and we can see your slides. Dr. Islam, we're just going to start with Tenzin and we'll come back to you.
So, first of all, good morning, or maybe afternoon or evening to all of you participating in this AppMan enhancing community level surveillance to ensure quality services and sustainable malaria elimination webinar. I'm here to share some experiences on community-led initiative towards malaria elimination in Bhutan. There was a slight change in the presentation title. So I would like to, from the one that was shared earlier, and then, so my presentation title, the new presentation title is Community-Led Initiative Towards Malaria Elimination in Bhutan. Next, please. So to give an overview of the presentation, I'll briefly touch on malaria situation in Bhutan, its success and challenges towards elimination, and then community health volunteers in Bhutan, then community-led initiatives for malaria elimination, and then efforts to sustain community initiatives and volunteerism undertaken by the national program. Next, please. So with regard to malaria situation in Bhutan, as seen in the graph, we are almost close to elimination with 2022 and 2023 reporting 0 indigenous cases. But if you look on the right-hand side, the malaria risk map, we still have like constant risks of malaria importation from across the border, international border. Next, please. So to highlight few key points on successes and challenges with regard to malaria elimination in Bhutan. For the case we have already seen in the first graph. So the other success that we have achieved is we have successfully malaria surveillance system that not only reports detected malaria cases, but also all malaria cases that were screened, and then number of tests performed. The surveillance system also captures investigations done and includes surveillance for logistics such as drugs and kits, entomological surveillance, and vector control coverage. With the help of Global Fund and WHO, we have successfully established a reference laboratory and quality assurance for diagnostic services. We have universal access to diagnostic and treatment services across all levels of health facility. Then we have universal coverage of L lines and iris for at-risk population. And then, in order to offset the human resource attrition in malaria, we have started with diploma in entomology and parasitology course. As regard to challenges that we face towards elimination, we have high transmission risks from across the international border, and we have challenges associated with close proximity of human settlements along the border. There's also high population mobility across the border, which is very porous, and that we have frequently seen like importation of cases and then importation and introduction of cases from across the border. We also have challenges associated with near malaria elimination, which manifest in the form of community perception of malaria, and then their adherence to preventive measures, and challenges such as delayed diagnosis and delayed health-seeking behavior from the community. Next, please. Now, finally, coming to the main topic, community volunteers for health in Bhutan. We have mainly village health worker and community action groups as a volunteer health worker in Bhutan. Village health workers was initiated first in 1979 to address the constraint in human resource shortage and then the accessibility of health in remote parts of Bhutan. We have a separate program for village health worker, and then the program trains the village health workers for a 2-week period, for a period of 2 weeks, and then yearly they were given refreshers course. The trainings are mainly focused on first aid, public health, and treatment of minor illnesses. For community action groups, the National Malaria Program started forming the group in every malaria endemic districts from 2009 onwards to support malaria control and elimination. The aim was to encourage community ownership of health, stimulate decentralization of health activities at the community level. Currently, we have 137 active community action groups with 971 members in all the villages of 7 malaria risk districts. Village health worker serves as the chairperson, and every community action group in every villages, we have a minimum of 7 members. Next, please. So with regard to the role of village health workers in Bhutan, village health workers forms a crucial first point of contact for health services in remote parts of Bhutan. They play a key role in improving the health standards within their communities. They are also a part of community action groups and serve as a member secretary. Specifically in support for malaria elimination, they refer fever cases in their communities to health facilities. If you look on the right-hand side, the register, on that register maintained by a village health worker, you can see about 10 fever cases referred to a hospital in the month of November in 2023. They also assist health workers during proactive and reactive surveillance for malaria. They assist in conducting indoor residual spraying in malaria risk areas. Next, please. For the functions of community action group, the main purpose of community action group formation was to identify primary health issues in their communities, develop plans to address those issues. For malaria, in order to enhance surveillance in the communities, they have been trained to recognize signs and symptoms of malaria. They were given a basic training on identification of vector mosquitoes, breeding sources, and their management, monitoring of L lines, coverage, LLN's coverage, their use and practices in the communities. They are also trained on indoor residential spraying and are involved in IRS in their communities. Though they have multiple, they addresses multiple health issues in their communities, but certain mandatory activities for malaria remain in their annual work plan. The picture we have seen on the other right hand side is it's a reporting format based on their annual work plan. So all those pictures are the activities they have carried out. Next, please. So here you can see community action groups with community members conducting cleaning campaign in their village. Next, please. The community action group members are, like I said earlier, they are taught basic knowledge on identification of vector mosquitoes, their preferred breeding sites. So they regularly, monitor their community for any opportunities for breeding, and then they try to destroy or modify those breeding sites. And then some of them also they can identify larva species up to genus level. So the picture on the right, you see a man sitting at a fish pond, trying to identify what sort of larva it's harboring. So irrigation canals, they maintain they remove all the vegetations to prevent anopheles from breeding. The betel leaves you see hanging on those betel nut trees, because the betel nut leaves, when they fall on the ground, it collects a lot of rainwater, and then we see a lot of Aedes mosquitoes breeding there. So they come up with this idea to, keep them hanging or either burn them. Next, please. Community, occasionally they also visit their village and inspect whether people are using LLINs or not, and not only in the community houses, houses in the communities, but also people who got crops at night. So they ensure that the people there also use mosquito nets for protection. Next, please. So while community action groups are important resource for malaria elimination in Bhutan, keeping them motivated and their activities sustained in the absence of financial incentives requires constant effort. Some of the strategies the national program undertake to sustain their volunteerism include maintaining a strong sense of purpose. So whenever we have opportunities to meet them, or whenever we conduct meetings and trainings, we constantly remind them of the national goal, regional goal, the global malaria eradication and elimination goals. So
Tenzin, your
next,
time
please.
is run up, so if you could just try to wrap up quickly. Thank you.
Thank you. Next, please. So another strategy to keep them engaging is by providing opportunities for growth and development through trainings and workshop. The trainings are provided, developing work plans, setting indicators, etc. Other than malaria, disaster response, first aid, HIV, TB, suicide prevention. So all those, and then they engage them. To sustain them, we make them make their own. Identify their own community issues, and then make their own decisions on how to address those issues. So that's one strategy to keep them, sustained. Next, please. We keep the volunteer activity flexible. They determine their own schedule for each plant activities, because they are mostly engaged in farming works. And then we, to motivate them, we regularly acknowledge their effort through giving away certificates, public recognition, or simple word of appreciation from our field staff. Next, please. Sustaining motivation is another important strategy to keep them meaningfully engaged for our elimination efforts. So we provide, in order to sustain motivation, we provide incentives like dignity kits in the form of gumboots, umbrella, cap, etc., and then certificates, social recognition, etc. Then we celebrate annually milestones such as years of service, project completed, or the number of hours volunteered. And then we also, like, whenever there are official visits from WHO or like from Ministry of Health, we provide an opportunity to meet with them and then showcase their contribution towards malaria elimination. And then support from local government also has some motivates them, like either support from local government means either in the forms of refreshment and like the request made by the community action groups to purchase. I mean, if you see in this picture, the waste collection bin. So I mean, those sorts of small things motivates them. So next, please. Thank you.
Thank you very much, Tenzin. People are already saying very informative, and I look forward for the questions when we listen to after we listen to the next two panelists. So, Dr. Islam, it's now your turn, and hopefully we can maintain connectivity. Over to you.
Thank you. May I move to the next slide?
Your slide is seen by us.
Yes, I think it's okay. I can make it happen, no? No, yeah. So we have 64 days.
Dr.
Dr.
Islam, we're not hearing you now, and you keep breaking up. Over. Dr. Islam, can you hear me? No, he's gone again. Can we maybe go to Vieng's presentation and then we'll come back again, try Dr. Islam. Sorry about this, everyone, but we can land people on the moon, but we can't keep Zooms going. Vieng, over to you. Vieng's slide is... Vieng?
Yes, can I share my slide a little bit? Okay. I be allowed to share, right?
Yes, of course. Vian, go ahead.
Okay. I do my. Okay. Sorry. I share again. Sorry. Okay. Thank you so much. Can you hear me?
Yes, we can hear you. We've got, it's not in presentation mode. We can see your sides, but that's probably okay.
Okay, I will do quick about the community level for surveillance experiences from Laos. So I think that's the I have 2 slides to share. I was not going to much take a time, but I would like to share only the surveillance that we have experienced to work in Laos. So I think that's the what we have done so far from the from Lao PDR regarding for the mechanism having for the community level surveillance. So we have one is this as you be aware that the civil society in Lao implement in the South province for 5 provinces. It's have take around nearly 2,000 of the village. This is the response by civil society. For the right for E, because the right 3 is the nearby 1,000, but right for E is an increase. So you can see the data report from the
Sorry,
PR.
Vieng, your slides aren't moving.
Is it moving?
No, we can still just see the front slide. Sorry.
Maybe internet. I can do a share again.
Being it's possible you're sharing not the presentation screen, so when you're changing it, it's not changing the PowerPoint. So just ensure you're sharing your presentation screen.
Okay, is this the don't share the presentation, right?
No, I meant don't share the PowerPoint application, but share the screen that is showing your presentation when you turn it on presentation mode.
Okay, okay, something like this. This one, right? Can you see it?
Yeah, we need it in presentation mode, though. We can see it's not in presentation mode. It's in an editing mode.
I think he's already put it on presentation mode, but he's sharing the wrong screen. So I see that he's already put on presentation on the bottom right. So you just need to share the screen that is the full screen with your presentation showing, not your PowerPoint or your other computer screen.
Can you see the second slide?
No, we can't.
Okay, I will send it to Sri, and maybe Sri can share for you.
Okay. So maybe just while that's happening, I'll take the prerogative. Now we can see second. No.
You
So
can see
people,
this
if
one,
you've
right?
we can see the photograph of people. Yeah, we can see number 2 slide. People, if you've got questions, please put them in the Q&A. Okay, over to you again, Vieng.
Okay, I go quick. So actually, we have done so far regarding for the malaria intervention is we do the government is allow civil society doing the malaria risk test and refer for the and also treatment and with the malaria infection people. Only the PV case that we can bring to the G6PD in the district level, and also in the provincial level. But we do also the treatment follow-up, and also we do a lot of the stock out regularly checking in the village level, and also in the health center. So far what we have participation in regarding for the surveillance in Laos. So we do a lot of civil society integrate about the community health worker. One is the active case finding. Secondly, we do the data collection together with the system, and also we do the data report, because every month we have to report to the health center and also the district level. The secondly, what we do is the data system and integration. So we help the government and also partner to have the system collect data and disseminate data for the community, because when we do surveillance many times, the data report is not go back to the community. Therefore, in this time, our team is to have the result from the surveillance, and then we go back to the community where is the outbreak is happen. So this is the one good thing that the government have very appreciate for our help. And also we do the local registration, register, maintain, record the case, because if one case happen in the village level, in 2 cases, so we report them immediately. This is one thing they know. The people receive training, they know how to report. For example, in the case is happen in the south, like in the Samui district. So they report directly to the health center, and then we can respond of the outbreak immediately. So the first one is that we have the DSS2. DSS2 is in Laos. It's a data health information system tool. It is supported by WHO. This is going to the health center entry data, but our team is help collect the data and then entry the data every month in the health center. This data is system you can see the real time, and you can go back, you can check it is the which village is that you can test how many people you can is outbreak data, and also how many case positive, how many PV, how many mix. You can see very real time, and we upload that. And also our team they know how to do the entry data every month. And also the data management and analysis. I think this is one important thing for the civil society engagement, because before the government not allow us to do the analysis, but now with the support by UNOP, they support us to do the how many the data show that the result and also the gap, so we can have the regular monthly or quarterly meeting about how to ensure that the data can tell us how to improve the system. My last slide, I think that's the third one. What we do, we join the surveillance with the local authority. This is the every time when the outbreaks coming, so our team is be there with the local government. And so we have also we join the resource allocation, because we have the personnel, we have supply, we have training. I think that's the own of the community engagement from this outbreak. And so we have the policy implementation. So based on the policy, the surveillance from national program, before we don't know about that, but now they make very simple of the guideline and for the community, so we receive the training. And also community really engaged of this campaign when they have the outbreak. Every time we use the civil society and community to do campaign, how to do the malaria education, and also promote about community participation, not just only malaria, but integrate about the other disease, because in the RIFO we have the integration where is the no malaria case in the village. Lastly, we the routine surveillance meeting and data analysis. So I mentioned already. So we have regularly meeting with the health center and also district level, and also have in the central level quarterly report. Also be checked and also evaluated by the technical team, including WHO. We can see that's the data from the civil society is not clear, then we can come back very clear to them. I think this is the and also last I think that's we do planning every monthly planning with the community people, with the village level. So this is most of the thing that we have done, so we can integrate about other disease, not just only the malaria. So thank you so much. This is the one of the participation of the surveillance by the community people in Laos. Thank you so much.
Thank you very much, Vieng. So we'll have questions at the end. Dr. Islam, we're going to try again. If we still have problems, I believe Dr. Amit, who's online, might present on your behalf. But let's let you have a try, please. Over to you again.
Thank you. Extremely sorry for this poor networks. So, Masai, can you go for the next slide? Yeah, I will be not much. Bangladesh has 64 districts. So out of 64 districts, basically 13 districts has a malaria endemic. 10 is a low endemic and 3 is high endemic. You can see in the right, basically in the marked in the both corners, bordering with India and Myanmar. So these are the, well, and the just 51 district doesn't have the malaria. So next, can I have the next slide? Yeah. And in BRAC, basically, we started malaria program in 1998 in Chittagong Tracts after the peace agreement signed between these two groups, and the local groups. And thereafter, slowly we expanded the malaria elimination program to all 13 districts with the Ministry of Health support and close collaboration with the malaria elimination program. We do have other partner angels to work with us, and finally, from the 2007, basically we also recipient of the finance from the Global Fund. So that also strengthened the malaria elimination efforts, both public sectors and private sectors in Bangladesh. Maybe next slide. Yeah. In this, you can see these slides is any kind of a community mobilization. That's what the main part of this, our malaria elimination. In the community mobilization side, community health workers played a critical role, particularly in informating the malaria elimination to the communities, and particularly go for case detection, reporting, and then also the responding, particularly for malaria in this case, treating these malaria patients, and also prevention with LLI. So malaria elimination, the community health workers are really playing a critical roles in terms of information dissemination, prevention, case findings, as well as reporting and responding immediately on the community. So these are the basic response to the community health workers that are being played in the community level. Next slide. And while we were thinking for the community health worker, basically we tried to identify multiple types of community providers. In some places we do have a comprehensive community health workers. They do more than malaria services like primary healthcare services. But in some settings we do have only malaria workers because the remote sites doesn't have on the numbers of few people have been residing there, or maybe a kind of a paddy fields in the remote sites or in the forest goers intervention. So it depends on the way that we deliver the services with number of community providers. Some are community volunteers, community health workers, mobile malaria workers or mobile health workers, and also some of the staffs also do a kind of a malaria test and provide the treatment. So all these people basically engaged in malaria elimination efforts, from the awareness raising to the case finding to the response to the reporting, and to put the connectivity with the public sectors and private sectors. The next slide. We do have as I talked about in 10 districts, that's mostly used as the control areas because malaria reduction very significant in this area. With the 3 districts, we have a high endemic area. So 5 districts we have a high endemic districts, and 8 is the low endemic. So in the 5 districts, but we have a very strong malaria surveillance system through community engagement. While in control area, we do have a limited presence in community level, but we do have a government public sectors to play roles in terms of information dissemination, collecting this information for the cases, and reporting to the government surveillance system. So more on the real-time basis in the control areas, while in elimination areas, some are also real-time through the community health workers, through the health facilities, but also through the offline data entry. And then when the people comes to the closer to the networks, they deliver this data to the system. And then again, both said we also do the kind of a response together. So we see the community has a huge role in terms of not only disseminating messages, but also identification, screening, and also reporting to the system, so that we can make an adequate response on the ground to make the prevention either a reliance or breeding source destroy, or community to be given attention on the particular village if it is hotspots. Yeah, so this surveillance system, yeah, this is basically what I also talked about in the earlier slides. We also, this data is also transferred to the government and also the DSS2 systems. So both from the public sectors and then private sectors also collect the data from the ground, village level as, facility level as, and hospital level as, and then puts to the DSS data too. It's connected to the DSS data, the government system. So you have only one single data, ultimately we received from the public sector. The next one. Here, basically, if you see in this area in its control area, you can see it's one of the we just do a kind of GIS mapping on the area through this community surveillance system. We put the system so we can understand where the cases are coming in. And that's one of the big part that we have been also working closely with other partners like MORU and WHO and then the national program. So we do a kind of other system to GIS. So when you data entry, you can see also the spots where the cases are coming in, and you can put your efforts for interventions and responses quickly. With this very strong, community system surveillance and the effort that we made it from last nearly about 20 years, you see the malaria cases with reduction from the for the last 1 decade. I have been projected here is 60,000 to that is around 2,000 cases, 3,000 cases, 30,000, 20,000 cases, but the deaths reduction significantly reduced. It comes down to around 10. Nearly about 10. So you see the significant reduction of the cases. So the CBI case also reduction significance and also the death reduction significance because there have been quicker responses if we made it. The delay will be the less in terms of treatment, and there will be less chances for the death of the cases. So it has a testimony of if you have a strong community-based surveillance system, along with the facility-based, you could basically identify cases earlier stage, and you can cure them, and you could have a very less chance for severity and very less chance of death. So it's a very clear, While we also seen the other, problems we have it right now in the Cox's Bazar. We have a Rohingya population nearly about 1 million refugees from this Myanmar. In the beginning, there was no malaria cases, but the last couple of years we are finding many malaria cases. One, perhaps due to the people are moving illegally, but people are moving to this forest for the cutting the trees for the livelihoods purposes, moving around. So the cases are being increasing, and also there's waste management also very poor in the camps. So that may be another part of the waste management and the drainage system management. That is also another area that's because the vectors are being present perhaps by that time, since the cases are coming in quite a lot. So as you can
Dr.
see,
Islam, if you could just hurry up. Thank you. We're near end of time. Thank you.
Sure, I have maybe 1 or 2 slides. So you see the another problem we are having with the refugee setting. So that's maybe they're going to the another attention that is take it if we'd like to have the malaria elimination in the country, because it is within this the Bangladesh boundary geography. So we can't avoid this, poor, progress in this refugee settings. So that gives us a kind of a remind us to have a strongest presence there as well. Next slide. And if you see this entire cases, this community contribution, like communities, in terms of, case identification, reporting, and the responses, you see the big numbers, either health volunteers or special health workers or community health workers. It is almost 80% or close to the 80%, 90% are coming from this community setting. So it's also have a kind of a way that you identify cases a bit earlier stages. That's why you have less severe cases and less deaths. Go for the next slides. Major challenges we found is, I talked about it. Geographically, the barriers is one of the, because it's the remotest sites. Malaria is mostly in the remote and hill areas right now. So the maps is going to be shrinking, but the remote sites being critical area for reaching this. Accessibility is another area because health facilities are not there. The increase also the buybacks, that's also a long-term treatment required. And also this Rohingya populations, we need to strengthen response over there. Cross-border collaboration, particularly the Myanmar and then India required, because this is very much bordering area, as I showed it, the case are coming in. If I saw the JS map, case very basically coming closer to this bordering area. And of course, the other issues, that the barriers of the language and also the waste management that I talked about it. So if we look into this, what basically, we come up across, because that's number one is basically we really need to have a, more community-based surveillance system, which including awareness rising, early notifications, screening, reporting, and response. So that's one of the part that we said we basically need to be very strengthened. The second part, when you have a surveillance strengthened, basically that will also give us a kind of a way of ensuring the accountability for response. If you do not know the cases are coming in, basically you do not know this, any response there. So this is surveillance is basically is a platform or the intervention that also gives a kind of a accountability on the health system. The third one, we also have a kind of the remote side. So we do need to be a special focus for the remote side. That's bringing this malaria interventions maybe a mobile rather than facilities, because you don't know exactly where the malaria case are coming in. So you need to have a transportation services. You may need to have a mobile services there, so you can have a better coverage, and then you can have the more areas to be recovered from the malaria free. And of course, the last one is the treatment follow-up and supervision, because if you can have that part is well done, so you could have less chances for being severity, and then you can always get cured this patient. So that's the basic lesson that we have between community sites. One is community surveillance, another one is surveillance to accountability, another is you need to be agile to be learn from the community and act on that. I need to follow up interpret from the screening to the end of the treatment. So that's over from my side. Thank you so much. I'm extremely sorry for this internet trouble.
Na tikishay. Onik donabad, Dr. Islam. So if I could just have the other two panelists on the screen, I think we've got time. I'll use a question that's common in the Q&A. So I would ask Dr. Islam, Vieng, and Tenzin. The question is, how do you maintain the quality of the data that's coming from the community level, and how do you also make sure that there's not discrepancies between the community surveillance data and government data, including the DHIS? So Vieng, also if you could pop your camera, Dr. Islam, so we can see you.
I'm not
so
sure, maybe.
Haha. Acha. Yeah, Dr. Islam. So how do you maintain the quality of the data that's coming from these community volunteers? And how do you manage discrepancies between data that comes from the community volunteers versus what the government information system may say from their health services?
Yeah, so I will respond to the first one. So we have the one system in the government sectors, so because we are part of the government response system. So what we do, we just put a data system on the system that we have it together with NMEP and background it. So there's no way of duplication. So the community does this community section part, facility does this facility section part. So there's no way of duplication, but you can aggregate at some point. But there is also a scope for a validation, because we do meet every month, So monthly meeting with this both with the government and this bracket staffs to be sitting together, so they can also validate this data, because we have that access, before finalizing the data. And quality basically checks the quality checks basically through the two steps. One, through our staffs to be checking with these community health workers through the records that we have it along with this reporting system. And the second part, when we do have also the quality of data with that we monitored every quarter independently and annually one time. So we have a data validation also separately going on.
Okay. Thank you. Tenzin, do you do similar things, or is there something a bit different that you do in Bhutan?
Well, here in Bhutan, as seen in the presentation, the community themselves decides what interventions towards malaria elimination they wish to do in their communities. So they develop their work plan and then carry out those plans, and then quarterly they submit some sort of data. So the activities that has been implemented for that quarter to the health facilities they are under the jurisdiction, under whose jurisdiction, health jurisdiction they are under. So they send those reports to the health facilities. And then annually we have like, we sit together, and then, I mean, they make presentations like for that particular year, what activities has been carried out in that particular community groups village. So we don't have like, for now, we don't have like data flowing into the national program, but they share the report, I mean, the interventions, the activities they have carried out to their, the health facilities they are under.
So do the health facilities do any validation of the reports of activities or people reached? Do they do any validation, or does another organization do some validation?
To be honest, like we don't have like, nobody goes there. I mean, there's no monitoring system because it's their own volunteerism. So we don't monitor those.
Okay.
But sometimes our health workers, I mean, they visit. I mean, the community action groups call them, I mean, the health worker, malaria worker, when they plan. I mean, when they execute those plans.
Thank you. Vieng, over to you. Same question. Is there something different you do from what Dr. Islam described?
Actually, we use the DSH2 is the main from the national, health. This is belong to the government management. So I think, but we can be allowed to access from that's the DSH2 system. But the second one, for the village health volunteer or village malaria worker, they use their own of the paper-based, because in each village they have, we provide them the tool of the paper tool for the collect the data when they do the malaria risk, malaria test, malaria treat, and also the follow-up, including of the monitor about the test kits when is the in each village. But for the civil society, we have our own COBO data, because we have the separate data. But this COBO data for our civil society, we can use among our network themselves. But we use that kind of data to compare between the DSS2 and our data, how it's different. Because the COBO data, so we not just only the taking about the indicator that's related to the DSH2 have, but we have the other more than of indicator that we recorded.
Okay, thank you. I think I've got time for just a one-sentence answer from all of you. That old problem people always raise, maintaining voluntarism. Tenzin, you briefly mentioned the role of incentives, but there's still people asking, is that enough? Particularly, all three of you have talked about how the community volunteers and the community are critical for the surveillance systems you've established. So Tenzin, is that recognition, a few gifts, giving the community a rubbish container, is that enough to sustain it, or do you think there needs to be something more?
I think, to sustain, I think the volunteerism, I think if government can have, or Ministry of Health can have like some sort of formal recognition of those community action groups, and then formal recognition from, I mean, Ministry of Health or government, and then if we can compensate for the time loss, I mean, being away from, I mean, volunteerism and then being away from farm, we have, I mean, they lose some time, right? So if we can compensate for those time loss, not as a daily wage, but I think definitely it will motivate them, and then it will enhance their volunteerism activity.
Okay. Vieng, I know that some of your workers, volunteers, actually get for compensation for expenditures they've done to do the job. You've got a system set up. Is that enough to keep them wanting to be volunteers?
Talking about the incentivize with participation. I think this is one also important thing. So we think that's the how, if enough or not enough. I think this is not I cannot say that's enough, but it's not enough. I think that's one thing is that we should develop of the appropriate incentive for village health volunteer worker and also community member who encourage them continue participation. This is really important. And also this could be include finance incentive and also training opportunity and also other recognition of the program. I think not just only money, but how we can think about that one. I think this is the Lao government already started.
Okay, and Dr. Islam, a one sentence answer.
No, it's fine. Yeah, thank you. I think that we do have an incentive for them, but it's not enough for them, because. But the one important thing, incentive is giving me the recognition to them, So it's one kind of respect to that at the time, It's not enough. But they have been respected and recognized, and the community also recognized them. They have been supporting them. So that recognition is required in the society. So they give a strong value for that. And I think that needs to continue within society, the value-driven society. So people will acknowledge the contribution of the society themselves who has been contributing. That spirit need to continue, but of course the government needs to always extend the support for that. At least a minimum they should recognize for the time compensation. Thank you.
Thank you. Thank you very much. Just everybody, there's a lot of questions in the Q&A, so I'll ask the panelists if they've got time during the next speaker to have a look, see if you can answer some of those. If other people have got questions, please put them in the Q&A. That's where we answer, and we will provide answers after this this meeting to some of those questions. I'll now hand over to Shri to do the next part of the presentation. Thank you.
Thank you so much, Maxine. Can you hear me?
Yes, we can.
Okay, thank you. Thanks so much. Good afternoon, good morning, wherever you are. My name is Srihari Acharya. I work for the CSO platform. So next few minutes, I'm taking you through the group work outcome that we organize in admin surveillance and VIVEX working group meeting our chair mentioned earlier in Kuching in September 2024. Can you move slide? We organized the one group work trying to introduce CLM concept to working group participant, but we also wanted to take that opportunity to understand what data, community level data is captured from a routine program and what is not captured, and what participant, including a National Malaria Program representative in that meeting would like to see community level data capture, which might be helpful for them to have better program designing and response. So you will see on the screen, we had 165 input from all participants. That includes participants from Greater Mekong sub-region, Pacific countries, and South Asia. We had three major themes for the group work, and one was the community-based service. Second theme was about the commodities, and third one was about the prevention of re-establishment. We were trying to see how community level data is useful and important for different malaria setting, from high burden to medium up to low burden setting. And in these two questions, all participants were asking during the workshop. Next slide, please. So there was long list of indicator or the community level data people mentioned during the workshop. You will see this table on the right side. Many data were some were captured, some were not captured, but top 10 from that discussion we pick is people wanted to have this treatment compliance data from the community level to be more capture and use those data for the national program designing for the treatment compliance to improve treatment compliance. The second one was community health workers data. I think that's also something overlap with other expectations you will see below the line. The third one was geographic coordinates. For example, it's like a household data, health facilities, even though local government or local authority has some kind of this high-level data, but community has all the detailed data regarding this. So the participants were also expecting if this data could be captured from the community level and put that or reference that somewhere at the national level data capture mechanism. The fifth one, you see the adverse event monitoring, and then vector surveillance, net distribution, stock management, financial related data. And there was a couple of indicators that has similar score, which is migration data, cross-border data, and other health-related data. And basically this majority of participants from the Greater Mekong sub-region were asking for this level of data to be useful if community can provide that linking with the national data system. Next slide, please. So here we want to take this opportunity because maybe not all of you were in that meeting. So, and then have this kind of verification also. If you also think this kind of data is not captured and useful, please participate in this poll. Poll is now already on the screen, so you can go. Maybe I can pause for some time and then let you participate in poll. And I will come back with my next and final slide. While you are scrolling this, you will also see on the bottom of this poll, there is an open text option. So if you would like to put detail related to indicators or data you are expecting that community level or community group could feed into to improve health planning and response, please be specific as much as you can. And here we are focusing only the data beyond the routine system. So any data that is not captured by the routine system, but will be very useful and helpful for program designing and response. So while you are doing this, maybe I can move to next slide. So after listing all this, the previous slide, what is captured and what is not captured, there was another round of exercise during the group work. We asked them from this long list, what is your priority if you are asked to do that? And there was kind of three categories we mentioned, the theme and key priority highlighted or picked by participant under the community-based surveillance was G6PD testing and studies required at the community level, febrile patient referral, and MMP data. With regards to commodities and drug, people were wanted to have more data as priority on the biosensor cost, treatment compliance, and the training effectively with regards to the supply chains and the treatment or the drug. The third category or theme is the prevention of reestablishment. On this, people highlighted that treatment supervision or supervised treatment, situation, the data analysis is more on the stratification of the area, and migration data, because the most of the when country are in the POR states, this migration always been very challenging because of many people can bring infection from other side to the area which is not having any malaria cases. So this is all, and then I think our admin secretariat colleague will double check with your input today, and the input many of you are other provided in coaching workshop, and perhaps that will help us to lead and then come with some of second level of summary and references. With this, thank you so much again for your time and participation, and I hand over to Secretariat.
Thank you, Shri, and thank you all our panelists as well as the moderator for being with us today. We are about to close our session shortly. I still see some people interacting with the poll, so I'll leave it on for a second longer. But after this, we'll do a really, really quick evaluation poll. So I'll give you 10 seconds before I shut this poll off. And just for your information, your responses to this poll will not only just help us understand the selections from the annual meeting more, but we will also be writing up these results up as a publication to report on the findings from the perspectives of the Asia Pacific countries on this topic and this theme as well. So thank you for your contribution. It will be published at a later date. For now, I'll end the poll, and thank you so much. We had a really large participation during the poll today, and we always strive to improve our tech talks in the future. So if you have an opportunity to quickly give us an evaluation before you leave, I'll leave this poll on until the end. For now, thank you to the panelists, thank you to Shri, thank you to Professor Maxine, as well as our co-chairs for being with us today. Until next time, thank you very much.